Okay, well, welcome everyone to Family Medicine Grand Rounds. My name is André Scarlato,
And I'm Laurie Bazna.
and we are both R3s at the Swedish Cherry Hill Family Medicine Residency Program, and both of us are at the CMAR Continuity Clinic site. We are really excited to get to talk to you guys today. Our topic for today is obstetrical care in Latin American immigrants and refugees. Before we jump in, we wanted to talk a little bit about just our inspiration for this topic to begin with. I think anecdotally over the past year or so, Laurie and I have started to see more and more patients in clinic who present around the third trimester and recently immigrating coming across the border. And I think we have both felt in ways how we can better support these patients through what they're going through, recognizing just the intricacies and complexities of crossing the border and establishing themselves within the US. And so for this presentation, we're hoping to be able to talk a little bit about some of the root causes, looking at the history of the movements across the border, talk about some primary care considerations as well. And then we're also going to focus a little bit on some trauma-informed care, because we also feel like it's important for us to start thinking through how do we come alongside these patients in meaningful ways who have gone through some pretty traumatic things in their lives.
We also just want to start with recognizing some of the shortcomings and limitations that we inherit within this talk. Number one being that there is limited information and data about people crossing the border, particularly pregnant people, in part due to a lack of transparency from the government. There is research, the research around undocumented immigration is challenging, given the difficulties and fears around the legality and disclosing immigration status. Anecdotally, we felt like we were seeing more patients from the Northern Triangle. The Northern Triangle countries include Guatemala, Honduras, and El Salvador. But in doing this presentation, we learned that at CMAR, we don't collect that specific information. CMAR collects information in terms of white, Black, Native America, and Latinx, but it doesn't specify immigration status or from which Latinx countries patients are coming from. And we also want to recognize that both Latinx and Hispanic terms are very broad terms that encompass many populations, particularly limited information about Indigenous and Black Latinx populations in the US, which are most often the most marginalized. Nonetheless, though randomized controlled trials may be limited, there are several human rights groups that are looking into obtaining data. And we also want to highlight that the testimonies from people affected from immigration are also of equal or more importance. In this presentation, we'll be using the term Latinx. And if you are not familiar with the term, it is the gender inclusive term used by some communities for Latino or Latina. Second, we also want to articulate that the data only reports on women identifying participants, and other gender identities were not well represented in this OB data that we were unable to uncover during this topic. We also want to recognize that talking about this topic may feel close to home for some people. We will be discussing traumatic experiences from crossing the border, violence on the border, ICE deportations, and violence, and hope that the way that we present this information is also sensitive to our diverse audience who may be having differing emotional experiences through this talk. We have no disclosures. And lastly, there is, during the last 5 minutes at 8:25, Dr. Huang will be speaking about a clinical trial that he is seeking our support from.
So moving on to learning objectives, the first component that we're going to start with is spending a good amount of time discussing the historical political movements and recent policies that we feel like are most relevant in terms of impacting obstetrical care. By no means will this be an exhaustive presentation on the immigration context, but we tried to highlight some that we felt were important for us to know as family medicine physicians. And then from there, moving on to talk about some of the prenatal risks that are associated with obstetric Latin American immigrants and refugees, and then provide some practice considerations for how we might adapt to that and change the way that we practice. And then within that, also starting to talk a bit more about some trauma-informed tools and considerations for how we approach these conversations and making sure that we're caring for these patients equitably. And then lastly, what we'll do is we'll spend some time applying this actually to a case study of a patient that both Laurie and I took care of who came in the 3rd trimester.
The focus of this part of the presentation is to lay the groundwork with some definitions in our presentation about being an immigrant and a refugee, and then also provide an overview of some of the current immigrant and refugee patterns from Latin America to the US, and highlight some key policies over time that have impacted refugee access to health insurance and also seeking healthcare. This will hopefully lay the foundation for further discussion around prenatal risk in Latinx immigrants and considerations for primary care involvement to advocate for our patients. Overall, it was difficult to uncover data very specific to the obstetric population crossing the southern border, but we have attempted to pull the most recent trends that we think both directly and indirectly impact pregnant people crossing the border. So just some definitions. So asylum just means that it's the protection given by the government to people who have been forced to leave their countries due to their safety or because of war. In the next couple of slides, I will also show some trends showing affirmative asylum applications and defensive asylum applications. So affirmative asylum applications are those from people who are seeking entry with a visa or already present in the US through a visa. And a defensive asylum application is when someone has no lawful means of entering the country and is asking for asylum, for example, at the border, or they are apprehended as an authorized migrant, and then asylum request is filed. For both defensive and affirmative applications, the person is obligated to file for asylum within 1 year of entering the country. This slide is a little busy, but let me just bring your attention to the top left corner. In 2010, we can see the total number of affirmative asylum applications filed were 28,400. And in 2017, in the bottom right, that number dramatically increases to 142,800. Also note that in 2017 is the first time from this data that China was not did not have the most asylum applications, and that actually Venezuela had increased to that #1 slot for the first time. You can also see that in 2017, Mexico dropped down to #5, where it had been #2 before, and then countries like Guatemala and El Salvador had more asylum applications than Mexico for the first time in 2017. In 2019, which is the most recent data we have available, you can see in the bottom right corner, the total number of granted asylum status was about 46,500 individuals, which had been the highest in decades, partly due to just an increase in the number of asylum applications. Under the defensive asylum applications, you will note that the Northern Triangle countries are in the top 5 countries being granted asylum. If you look at the total between El Salvador, Honduras, and Guatemala combined, they represented more than 16% of all asylum grants in 2019, compared to just 4% in 2010. So then, why are we seeing this increase in immigration? I think as primary care physicians, we often ask why, and we seek understanding of root causes of health disparities, and oftentimes find that capitalism, white supremacy, and racism are often at the core. When we look at the root causes of the immigration crisis, the United States makes itself present. There are several different recent civil wars that occurred in Latin America and the Northern Triangle. For example, Guatemala in the 1960s to 1990s, and El Salvador in the 1980s to 1990s. The US has did back some CIA operations in Guatemala, El Salvador, and Nicaragua that led to destabilization of local government in the name of communism. In Guatemala, they estimate about 200,000 deaths during the Civil War, of which about 83% were of indigenous and Mayan descent. Oftentimes, the US was involved in training officers in counterinsurgency techniques, and firearms imported into the Northern Triangle from the US during the Civil War have remained in circulation since, leading to violence. In 1991, former President Bill Clinton apologized for the US involvement in the Guatemala War, and he has a quote, which he states, "For the United States, it is important that I state clearly that support for military forces and intelligence units which engaged in violence and widespread repression was wrong, and the United States must not repeat that mistake." Then in 1996, former President Bill Clinton began deportation of immigrants, including legal residents who had been convicted of crimes. For example, the MS-13 criminal organization that originated in LA, people that had been affiliated with that organization had been deported into El Salvador, and now in El Salvador, MS-13 is one of the largest criminal organizations that has led to an increase in violence and increase in immigration.
So now, having established some of the historical context that has led to this increase in people from the Northern Triangle, specifically crossing the border, as well as the rest of Latin America, we wanted to also spend a little bit of time at looking at more recent policies that were under the Trump and Biden administration that have also impacted for this topic. So the first one that we really wanted to highlight was in 2017, when Trump ended the automatic release of pregnant patients from ICE custody. So during the Obama administration, it was common that pregnant patients who came across the border were not detained and that they were automatically released just because of the concern around pregnancy safety. However, when Trump came into office, then that was removed. And so what ended up happening was that there were increasing numbers of OB patients that were being held at the border. Looking at the data for this, it's a little bit difficult to know, was that because of the policy change versus just the increased number that were crossing the border at that time. But of note, there were quite a bit of testimonies that have been collected by Human Rights Watch groups that discussed increased concern about miscarriages as well as malnutrition. One of the testimonies highlighted that one of the obstetric patients had been identified as being malnourished and needing a high protein diet, and the high protein diet that she was offered was a piece of bread and some cheese. And so this is a huge policy that I think is really relevant for us to discuss. The next one, which I think many are probably familiar with, is in 2019 when Trump started the Migrant Protections Protocol, which also is known as the Remain in Mexico policy. And so essentially, for those that don't know, that is the policy that did not allow defensive asylum seekers to cross the border, and they had to remain in Mexico at that time until their application was processed. This led to significant safety issues at the border, large shelters and encampments that were created ad hoc as people were waiting. And then the US also dramatically increased the size of their detention centers, specifically 2 in Texas, which led to increased concerns. And then also in 2019, when Trump expanded what the definition of a public charge is I think also really relevant for us to discuss. So being a public charge, or being dependent essentially on the government for resources, was usually a pretty limited definition. It was something that had started actually in the early 1800s in the US, when identifying immigrants or refugees that may come and become dependent just on essentially the 2 things that were used at that time were disability, so SSI, or TAMF, which was the cash assistance for needy families. But during Trump's administration, what he essentially ended up doing was expanding the list of things that could increase one's risk for being considered a public charge. Things on that list that were included were things like SNAP or WIC, or even applying for Medicaid. Now, of note, there were exceptions for pregnant patients in this public charge expansion of the definition. But nonetheless, the expansion led to even more increased anti-immigrant sentiment within the country and fear around accessing these services. Additionally, some reports from the New York Times had done some extensive interviewing with primary care physicians and obstetric providers at the border that noted that there was a significant decrease in accessing prenatal care, even for fear of being seen by a physician or a provider at that time would increase their risk of not being granted asylum or not being able to apply for documents in this country.
Of 2020, the Department of Health and Human Services issued an emergency regulation to implement a specific aspect of U.S. health law, Title 42, which means if the CDC finds that a disease poses a threat, it can, with approval from the president, temporarily prohibit certain people from entering the country to avert danger from the disease. Amid the surging deaths of COVID, the Trump administration put forward a new interpretation of Title 42, which allowed U.S. Customs and Border Protection Agency to immediately remove anyone entering the country without authorization under the veil of preventing the spread of COVID. Sometimes Title 42 is confused with the Migrant Protections Protocol or the Remain in Mexico. Under the Remain in Mexico program, U.S. immigration officers will direct migrants from other countries to stay in Mexico while their cases weave through the immigration court system. The Remain in Mexico still gives migrants the chance to apply for asylum, albeit from outside the U.S. However, Title 42 completely prevents them from seeking humanitarian protections at all, as they are immediately deported. More than 1.7 million people did paid by the Border Patrol during the fiscal year 2021. And of those, 61% were expelled under Title 42 without allowing them to apply for asylum. And then when President Biden began his term in January, the new administration continued the policy, saying it was, quote, necessary to limit the spread of the coronavirus.
So now, having talked about Trump and COVID era policies that have really impacted more recently, I think it is important for us to touch upon some of the policies that have been enacted through the Biden administration. First, when he came into office in January, he reversed the executive order of holding pregnant patients at the in detention facilities. So that was certainly a positive. It was done by executive order, so there is some critique and concern around just the permanence of this legislation changing from administration to administration. And I believe in his clause there was more gender identities identified within the ability for those patients to be released at the border. And then in February, the Department of Homeland Security worked with Biden to start unwinding the process of the Migrant Protections Protocol to remain in Mexico. But unfortunately, I think it has become a much more complex issue, which we're not going to spend time getting into, but there have been lawsuits that have generated through the courts from border communities in the US wanting to re-implement components of it. And so currently there is some process to re-implement some of it. What those components will be is not really clear. There's been some suggestion that there might be some increased support overall for services at the border to help process asylum seekers, but that has not been published yet in terms of what that is going to look like. So we have been speaking quite broadly about immigration and historical context, and so we wanted to drill down a little bit into what does this actually mean for the obstetric population crossing the border. And to be quite frank and honest, it's really hard to find that information. Part of that is that there's just there's not actual public data that is available. There actually have been some human rights groups that have been demanding for increased transparency from ICE and the government to provide that information. And so there has been a call specifically for like the number that are crossing the border, the number that are detained, and more transparency around how they're being cared for. And as is ubiquitous within crossing the border, particularly for obstetric patients, the increased risk of sexual and physical assault, kidnapping, and extortion are pretty high and have continued to be been difficult. What we do know is that there have been some ICE custody statistics that have been reported. And so there has been an increase in detentions about by 50%, which you can see from 2016 to 2018. Again, it is hard from the data to pull out if this is from a policy change or if this is also just from like the increasing numbers that are crossing the border. And the data does not go into specifics around being able to pull out why that is. But what we do know is that there is an increase in detentions. There's some anecdotal concern for the increase in miscarriage like we were talking about. And then the one thing that has been reported is that the detention times have been increasing. So generally obstetric patients, if they were detained, the goal was to get them processed within 30 days. But there's been about a 13% increase in detainees that are obstetric of the obstetric population over 30 days. And then there's also been just multiple reports around poor living conditions, lack of access to medical care, really delayed care actually with higher risk obstetric patients and needing the monitoring that it is important for them to get, and then access to nutrition and potable water.
To some of these policies that have affected obstetric patients, there have been organizations such as Lazadas that have emerged. So Lazadas is short for Las Embarazadas, which means pregnant in Spanish. And this organization in Mexico, in Ciudad Juarez, they have a lawyer and a midwife on their team, and they provide free healthcare and legal advice, baby products for the patients or the people that they serve. It has supported about 120 women, and about 68 babies have been born with their help. A Time magazine article talked about Xiomara, who was at term and already having or presenting in labor when she presented herself to the U.S. border to meet her claim for asylum. She had to come from El Salvador and was fleeing gang violence 6 months earlier, and had been working on the table in Mexico to afford her bus tickets for her and her 3 young children. But when she arrived to the U.S. border, the Border Patrol offered to take her to a hospital, but because she had heard about family separations and was worried about her losing her kids if she were hospitalized, she instead went back to Ciudad Juarez, and fortunately found by word of mouth of Lazadas, and was able to get a shelter and complete her pregnancy there.
I think the last piece that we felt was really important for us to discuss was looking at health insurance access for the OB population when they are able to cross the border and come to the US before jumping into the primary care considerations. So the most important thing I think initially to start out with is to discuss the 1996 Personal Responsibility and Work Opportunity Reconciliation Act. So this was a bill that was passed during the Clinton administration. That essentially what it did is it put pretty significant limits around who could even access Medicaid within the US. Specifically what it did is it created a 5-year wait essentially for any quote lawfully presiding immigrant. So anyone who actually had documents at that time, if they were to enter in the US, they still would have to wait 5 years until they could even be eligible to apply for Medicaid. This obviously has been a huge barrier and has been difficult. And it's also important to mention that there was no pathway, at least for anyone who was undocumented, to be able to get access to insurance, which many of us are very familiar with that barrier. And so essentially what happened since that federal bill passed was that states ended up determining on their own how they were going to provide access. And so we'll see this in the next slide, but different states chose to either waive that, partially waive it completely, the 5-year wait. Specifically in Washington, I think it's important that to note that our OB patients are able to get access through Apple Health coverage. And then more recently, actually within this last year in April, Jay Inslee signed in an expansion to cover 1 year postpartum actually, which has now gone into effect in July. And I have to say it's been really helpful in my conversations now since researching this and talking with my postpartum patients who are often in a rush to make the next appointment and make sure that they can get the birth control that they need covered. And then lastly, I think it's important to know that when the ACA was passed, it also did not include a way for undocumented immigrants to be able to access care. And that was a component of trying to get the bill passed through that was let go. So looking at this next slide now, this is just a helpful breakdown, I think, of just the pretty large diversity in terms of who is able to access health insurance. And this is only for, just to orient everyone, it's only for those that who actually are documented. So this does not include undocumented and their access. And that is a separate issue. But those that do have documents, you can see the darker blue. These are states that have chosen to waive the 5-year wait for both OB patients as well as children. And then kind of the second darkest blue, those are those that have waived it just for children. The lightest blue is those who have waived it just for pregnant patients. And then everything in gray is actually all the states that still require the 5-year wait. So again, just the diversity, and even pointing to looking at the states at the border and their different policies that they have, I think is of note. So now moving into the second component of our talk, we wanted to spend a little bit of time looking at what are the risks for Latinx immigrant and refugee patients coming across the border, and considering some things that we might want to add to our primary care practice. So the first thing that I think is important to talk about when looking into the data and assessing what the risks are is first identifying what is the Latina Paradox. So initially during this research, what I had come across was that pregnant Latinx patients seem to have better outcomes despite coming from lower resources, which is this idea of the Latina Paradox. This is a theory that has been in place since the 1980s. And what they have found is they've done large population data of those that have come from Latin America, and they've shown that these patients have a decrease in infant mortality, as well as lower low birth weights being reported than US white patients when they come across the border and then deliver. However, I think it's important to talk a little bit about some of the concerns with this theory. Initially, I think one of the big components to mention is that it's a pretty broad generalization for a large population. So trying to encapsulate large data trends for large component of Latin America is really, really difficult. It does not really take into consideration other groups like such as indigenous populations, which are in some countries and not in others, to be able to really understand what are these risks. And they've actually done subgroup analyses that have contradicted this belief that Latinx patients have better outcomes. For example, there have been some studies that show that patients who have immigrated from Puerto Rico have higher risk of infant mortality and higher levels of low birth weights. I think another big issue that has happened from this is that it has shifted away some focus of trying to work with obstetric Latinx population in terms of health equity work, because the theory in and of itself has promoted the idea that things are actually better than perhaps they are. And I think sadly, it has also led to a lot of dangerous stereotyping, which many of us are aware of and have experienced, particularly I would say on the L&D floor, taking care of our obstetric patients and hearing comments about how the Latinas are such good pushers and that there aren't going to be issues, which is hurtful, and then also very much detracts from the increased risks that there have been shown. And that leads me to the next point, right, of other outcomes that aren't really being factored. There's some data sets that are suggesting that there are increased risks for preeclampsia and increased risks for GPM and large for gestational age babies within this population of immigrants, and we're not necessarily thinking about those. And then lastly, there's really a dearth of evidence around what does documentation status mean and how does that impact this idea of the Latina paradox. We'll talk about that now in the next slide, but it essentially is just really difficult to quantify who has documents and what does that mean then for their health outcomes. So now that I've sufficiently muddied the waters in terms of what is the data, I'm now going to present a little bit of opposing data of the Latina paradox to suggest that there are some increased concerns that we should be thinking about. So one of the important studies I think important to mention is a retrospective cohort study that was done within Colorado. It was published in 2005, so it's a bit old, but essentially it was looking at around 6,000 patients who birthed within Colorado and compared undocumented with documented immigrant populations. And what they did find was that those that were undocumented had later presentation to prenatal care, and there was concern around higher maternal mortality rate within that population compared to the US Latinx OB patients, and then an increased risk of labor complications and postpartum bleeding. Now looking more broadly, there was a more recent systematic review that came out in 2020 that actually looked at 9 retrospective cohort studies. And the bottom line, unfortunately, of that study was that there's really inconclusive data on risks for the undocumented Latinx immigrant population in OB care. I think of importance is to highlight the complexity and trying to identify that within research. So one, they were either being used by self-report of the patients sharing that. 2, they were looking at if they had put a social security number down, and if they had not, then they would include them as an undocumented member, or 3, if they were using emergency Medicaid as a proxy. So there were unfortunately very loose proxies that they were using to identify these groups. And so it was really hard to draw conclusions. And so with that, the only salient thing that I think did come out was that there's possibly an increased risk of postpartum depression. But again, this also continues to muddy the water on what exactly is the evidence base for the Latinx immigrant OB population. And so then I guess the question is, where does that leave us, right? I think looking at the evidence base made things difficult to understand what should we be focusing on. But I also think in conversations between the two of us, we have been talking about other sources of knowledge and ways that we are able to care for our patients. And I think that's through our own experiences of seeing these patients come into our office. So our own reports from that, and also a lot of knowledge of knowing where these patients are coming from and the trauma and the violence that they're also experiencing. And we know generally that trauma and stress is not good for anyone's physiology, and this particularly can affect OB population even more. And so what we wanted to do, despite the confusion around looking at the data that has been published on this, was to put a list together of some considerations that we feel like are really relevant for thinking through how to care for this patient population. I'm not going to go through all of these, but I'm just going to mention a few of them. I think one of the important things to think about is nutrition and pregnancy growth. What we do know is that, especially in the Northern Triangle, there's pretty high rates of malnutrition overall and food insecurity. And within the country specifically, patients that are from those countries, there's really high levels of low birth weights in those areas. And so I think it's important for us to translate that information then to when they are seeing us in the US and how we would care for them. I think some of the built-in ways that we already do that is checking bundle height and assessing for anemia, but making sure that they have access to food sources during their pregnancy as well. I think important for us to acknowledge that there's likely a lot of fear in accessing care, and also just integrating within our own US health system, especially with the public charge expansion. I think that's something important for us to consider. We will spend a little time talking about IPV screening. And then I think especially in the 3rd trimester, as it would be for any OB patient, think about what their RH status is and if they need ROGAM during that time. Fortunately, there are really high levels of immunization from the public health policies that many of the Central American countries have. So that is of one benefit for us, but also something for us to think about. And then I think lastly is really being even more intentional about offering doula support for these patients who are also acclimating to our US system. Now looking specifically at the CDC, I think this was actually a really important thing that we both came across in our research, but thinking about what are any extra screenings that we might consider adding on to these patients. So for Central American refugees, the CDC does actually recommend universal screening for TB and lead, which currently at this moment are not things that are integrated, I would say, into our practice over at CMAR and our areas I think that we really should consider adding. We don't necessarily have a screening tool even for knowing who is coming in recently crossing the border and making sure that we provide these screenings. For those that are coming through documented channels already, they are getting post-US visits, and this is part of that workflow. But there are many informal ways that people are crossing the border, and we also need to make sure we take care of them in those ways. Interestingly, Giardia, Helminth, and Chagas disease, those are all infectious diseases that are endemic in especially the Central America region, but there's actually currently no evidence at this time that screening would improve outcomes for these patients.
And it's not uncommon for us to encounter patients with a history of C-section in our practice, and oftentimes we don't have the operative reports. ACOG does note in their practice bulletin that pregnant people with one previous cesarean delivery with an unknown uterine scar type may be a candidate for TOLAC. And they cite 2 case series, both from large tertiary care facilities, where the reported rates of VBAC success and uterine rupture and unknown uterine scars are found to be similar to those of women with a documented prior low transverse uterine incision. I was trying to find data on seeing if by country I would be able to know what type of C-sections they were doing and what type of uterine scar was commonly practiced in different countries, but that is really hard to find. Anecdotally, I spoke to different providers that had worked in different countries, including Guatemala, and I talked to some of our like OB fellows. And it sounds like, at least now, we assume that most C-sections, they have a horizontal uterine scar, even if they have a vertical skin incision. The Swedish hospitalists take care over the labor of our TOLAC patients for CMAR, and they frequently offer TOLACs to patients with unknown uterine scars. It is just important to know that we should just ask our patients if they were ever told that they could not have a C-section in the event that they did have a vertical uterine incision. And then intimate partner violence in Latinx OBs, and in general, speaking of all women, about 3 to 9% of women experience IPV during pregnancy. There was a study in LA where Latina women were screened for IPV, and about 10% were found to screen positive for physical abuse and 18% screen positive for emotional abuse. There was a different study in Houston who surveyed Hispanic women, and they found that about 11% had experienced IPV during their most recent pregnancy. In the LA study, women born outside the US were more likely to report IPV than US-born women. When looking at if IPV prevalence increases or decreases during pregnancy, it's the data is not very consistent, and part of that is because a lot of these studies use different screening strategies or these different definitions, and so that data is a little bit less consistent. And then in the context of COVID, data suggests that violence, including IPV, increases during humanitarian crisis and emergency. Self-isolation and social distancing puts victims in a constant danger by the imposed proximity with their perpetrator, and it can remove some important protective factors such as moments of relative freedom when the perpetrator or victim goes to work, or access to support by additional people in private spaces. And then violence during pregnancy is associated with pregnancy complications such as preterm contractions, miscarriage, premature birth, stillbirth, and low birth weight. Screening for IPV in pregnancy, the U.S. Preventative Services Task Force recommends screening for all female patients of childbearing age for IPV, and that's a grade B level recommendation. It is important to know that screening alone does not reduce negative outcomes, but interventions do. And there is no well-validated tool to screen for IPV. I use the HITS example here. Hasn't been hurt, insulted, threatened, or screamed at you. But that's just an example. There's actually no well-validated tool. And then coming back to trauma and different experiences of our population, providing trauma-informed care is something that I felt like I personally needed to grow in and further educate myself on. Trauma-informed care means recognizing the pervasive impact of trauma on health and how it applies, and to apply this knowledge of trauma and its consequences into practice, and actively seek to prevent stigmatization. Different practice styles that can help would be practicing strengths-based approach to care, meaning gathering information about family support and recognizing that strengths can build resilience and promote healing. For example, about strengthening family supports, asking if something difficult were to happen, who would be able to help. Promoting trusting relationships. Unfortunately, healthcare environments, we can also be a source of trauma and racism for immigrants. And as a healthcare provider, creating a space that is inclusive and immigrant friendly. For example, providing signage that says like all are welcome here in multiple language. Recognizing the impact of trauma and screening for associated mental health conditions, screening for depression, anxiety, and PTSD. Potential sources of trauma can include family separation, either planned or unplanned, physical or sexual abuse, dangerous conditions during migration, and family conflict and intrafamilial violence as well. And then also recognizing that trauma may not end after migration, and that trauma in the US can also be in the form of racism and bias and microaggressions that can continue long after migration. And the importance of advocating for our patients and pushing for immigrant-friendly policies, a diverse healthcare workforce, and anti-racist policies.
In line with thinking through trauma-informed care, I think an area that I especially felt like I have needed more work in and continue to work more in is around the nuance in communication and making sure that our patients who are coming across the border feel safe in having these conversations, and also not kind of recapitulating the trauma that they have gone through. And so what I wanted to do is just provide some examples. I know it's wordy, but provide at least some verbiage for us to consider and think through. By no means is this the perfect or exhaustive list, and I think we're still working on it, but this was done in collaboration with a few other providers at our clinic to get a sense of how do we talk about these things sensitively with our patients. I think the things I'm just going to talk about are the bolded bullet points, but just making sure that we're being very explicit up front that their immigration status and details, or the immigration status is confidential, and that the details of what happened, knowing explicit details is really not necessary. Like we do know with trauma, talking about the trauma isn't always necessarily therapeutic, and it can be significantly re-traumatizing. And so making sure that they don't feel the pressure to be able to specifically talk about it. I think also asking permission and borrowing from the motivational interviewing tool set is really important. Whether that is us asking them and allowing them to feel like they can decide when to talk about it is one option. Another option, which I thought was interesting when reading about some sanctuary doctoring data that's out there in interventions, is that actually patients, when they check in at the front desk, are given a card that says, I would like to talk about immigration. And then if they choose to bring that up, if that's something they want to do, then they can leave it and give it to the physician or the provider in the room as basically a symbol of saying, okay, it is okay for me to, it is okay for you to ask me questions because I have some questions I want to bring up. And then I think sometimes too, it's helpful even just to offer up some themes and say some people who are crossing the border struggle with these things, or these are things that have happened to them. Is that anything that happened to you and that you want us to know about? And are there ways that we can help support you? And I think, right, the bottom line to all of this is that it's not asking to know just to know, right? It's asking to making sure that we aren't missing things and making sure that we give them the access to the care that they need. So moving now to the third part of our presentation, having now given some context for the history and policies around it and the recent influx, talking about some of the primary care considerations, we wanted to apply some of this information to a case study of a patient that both Laurie and I took care of that came from Honduras. So some of the details have been changed just for confidentiality and HIPAA compliance for this patient, but most of it is essentially the same. So this is Victoria. She is a 21-year-old G1P0. she presented on my schedule on an afternoon one day, saying that she had just crossed the border and that she was here to establish her pregnancy care. Based on her LMP and an first trimester ultrasound that she said that she had in Honduras, so didn't have the sheet with her. She said she was around 30 weeks and 4 days, basically. She had shared with me very briefly, though I didn't go into details about this, that she had come because she was fleeing violence from her home community and that she had came alone. She did say that she was married and that the father of the baby was on their way, but it wasn't really clear what time that was going to be, and that her sister as well was in the process, but she had lost communication with them through the travel. Of note, when I did her fundal height, she was measuring around 26 centimeters, significantly lower than her stated 34. But we essentially got all referrals started. We started her on prenatals because she hadn't been on those, and got her close follow-up with us to make sure that we had another touch point of care. I think upon reflecting myself, I think this was admittedly was a overwhelming visit in some ways, to think about how do I make sure I get all the essential things done in this visit, recognizing that I can defer some things to other visits as well, but feeling the challenge and the responsibility to make sure that we covered everything in that time. So then 3 days later, her tests had come back. Her labs all looked really great, except she did test positive for chlamydia. I was able to call her over the phone and send the treatment to her. She was not sexually active with any other partners, and she didn't have a way of communicating with her partner at that time, but would be notifying him when she was able to communicate with him.
And then I saw her at her follow-up visit when she was 32 and 4, and she was RH positive. She had completed her treatment for chlamydia. She was again measuring size smaller than dates. I reviewed her ultrasound report, and it was largely unremarkable, other than that there were some fetal parts that were suboptimally visualized because of fetal presentation. And at that time, again, the father of the baby and her sister were on their way. A repeat ultrasound was ordered because the anatomy wasn't fully visualized. And at this point, the estimated fetal weight was 14%, but the abdominal circumference was now at 2%, which indicated that her pregnancy met criteria for IUGR. And so it set up her antenatal monitoring and it discussed induction of labor at 39 weeks. Notably, her first maternal support services MSS appointment was a few weeks after her initial visit, and she had no-showed to a visit and then had to be rescheduled. And at that time, she was able to get signed up for WIC, and food insecurity was identified.
So then moving on to her interpartum care, she presented to L&D on the 9th, had a contraction stress test because of her IUGR status, and did very well with that. And then really progressed and had a really normal delivery after that, with no major complications. She did deliver an AGA baby of note, so was not SGA. But I think important to highlight is that she did deliver alone. The father of the baby was still delayed at the border. She had received notice that her sister had been able to cross the border, though hadn't had contact and knowing when she was coming. Then on postpartum day 1, when I rounded on this patient, she had shared with me that her sister had been able to make contact and would be in Washington within a few days, which she was really looking forward to. And then I saw her a few days later for a newborn visit, and she was doing really well as a first-time mom. The baby was gaining really good weight. She was breastfeeding with no issues, and there was no concerning signs for postpartum depression. And then just a few weeks ago, I saw this patient for her postpartum visit, and overall is continuing to do really well. Bonding, no postpartum depression, breastfeeding still has no issues with it. We were able to get an appointment for her to get her next Nexplanon, and she had just shared with me that the father of the baby was finally able to enter the US and was hoping that he would arrive soon. She had shared that she continued to get good support from her cousin, who had she had been living with since she came to the US, and her sister now. So I think all in all, it was a really good outcomes for this patient, but I think we wanted to spend some time talking about what we felt like went well in areas that we think could be improved on, especially after going through the data that we've been through at this point. So I think some of the highlights, honestly, that I can think of would be communication. I think that oftentimes can be really tricky with some of our patients who are recently establishing in the US and not always having the most consistent access to cell phones or ways to communicate with us. And in fact, she sent my chart messages back and forth, so that worked really well. I think we were able to get her chlamydia promptly treated after we recognized it and screened for it. And then we actually, with our OB coordinator, were able to organize her antenatal monitoring, which oftentimes can be a bit complicated, especially within someone who qualifies as IUGR. Areas, though, that I think we really could improve in would be one, lead and TB screening. Those are things we did not offer, and that I think after reviewing CDC recommendations would be important for us to do. And then secondly is just more of a, I think, intentional trauma screening. As I reflected on that first visit too, I think I didn't feel like I had the tools and still learning how to talk about those conversations is an area of growth for me. But I think it would have helped us actually identify a little bit quicker that she did have increased concern for food insecurity. I think that's the biggest area that we could have done better on in serving this patient. She unfortunately had a very delayed entrance into the maternity support services, which was 6 weeks later after she saw me. And so while there's some built-in support systems that way to screen for food insecurity, I think both from having a more in-depth conversation and then also taking a little bit of time on myself to think behind the why of why her fundal height was lower would have been a meaningful way for me to think through about access to food. And then I think the last few things too would just be being more intentional about offering doula support to this patient after I had identified that she would likely not be laboring with any support system, offering that to her, which I think could have been improved. And fortunately at Swedish, there is a good group of Spanish-speaking doulas that are able to support our patients. And then finally, I think an area that we could have helped her with more would be supporting for seeking asylum, if that was something that she was doing. I had not explicitly asked her that.
The key takeaways from this presentation, I think the first one being that there's a lot of complexity and limited data around some of the challenges that our Latinx obstetric patients face. There is more need for transparency around care for pregnant patients at the border, and then also need for more intersectional research, particularly around people who identify as Latinx and Indigenous and as Black Latinxes. In terms of primary care considerations, incorporating lead and TB screening into our practice. Also just the increased need for trauma-informed communication, and I think both for André and I being an area of growth that we felt that we needed more support on, especially around the border-related trauma, and then also the need for more immigration reform and more compassionate care and reparations to countries affected by US intervention.
That concludes our presentation. If there are any questions, feel free to pop them in the chat. It looks like there's a few that we will look through now, and then I believe we have probably about 2 minutes maybe to answer questions, and then we'll hand it over to Dr. Wang.
One question is, are there issues around WIC access and immigration status regarding the public charge and patient fear? I think anecdotally, I have had patients that because they're currently either applying for asylum or that they decline WIC services. And so at least in clinic, I've had patients decline some services like WIC because their immigration lawyer actually told them not to. And then I think there is just a comment here, but no question. How to refer for appropriate legal consultation or services.
Thanks for the comment, Dr. Cooper.
And then I think final question that we'll have time for is, has Spanish literacy been a complication to communication or not so much? I do have patients who do not speak Spanish, and oftentimes if their partner is here, a lot of times their male partners will serve as interpreter, which of course adds some complexity to those visits.
Yeah, and I would say for those that are, I think there's a small subset of patients that are indigenous speaking as their primary language of one of the Mayan dialects within Guatemala, and I think we struggle even on L&D of getting interpreters for those patients. I personally haven't run into literacy issues with my patients, but oftentimes, yeah, what Laurie was saying is the male patient would be able to know how to read. Good question, Daniel.
We integrate TB as lead screen. I mean, we haven't really talked about it, but I imagine it when we get all our initial prenatal labs would be a way to do it.
Yeah, I think so, Mary. I think even a stop question within our our template that we use for what we ask in a prenatal intake would be a question around like, have you recently arrived and have you had these have you had these screenings?
Well, thank you all so much for joining us. And then please stay on the call. Dr. Wong will be giving a quick talk on something that he is doing.
Hi, good morning. Thank you for having me join your conference. Let me share my screen here. I trust you guys can see the screen okay. So I want to talk about a clinical trial that we are doing in Swedish. It's called Radiance 2, and it's a trial for patients with hypertension who are not responding to medical therapy, at least not adequately. We know hypertension is prevalent in our society, and many of the hypertensives are not diagnosed, and many of them are not treated well enough. Essentially, 33% are struggling to achieve good hypertension management despite multi-drug therapy. And so the trial that we are conducting at Swedish is a trial looking at denervation of the renal nerves to treat overactive renal nerves and so manage hypertension better. So the role of sympathetic activation is quite well understood in mechanism for hypertension. Both the efferent and the afferent renal nerves are important in this mechanism. The efferent nerves can cause increased renin increase, which leads to a decrease in renal blood flow, and that leads to an increase in renal tubular sodium retention. The afferent nerves, on the other end of the loop, increases the sympathetic outflow and therefore causes vasoconstriction. So these mechanisms together can initiate and exacerbate hypertension. So for many years now, catheter-based technology has been looked at as a potential modality to disrupt the renal innervation. In so doing, facilitate hypertension management. And so this particular trial looks at the use of ultrasound technology to achieve renal denervation. And this is a schematic diagram of how this works. This is a catheter with a balloon that's inserted into the renal artery. Inside the balloon, there's a coolant circulating to cool the device, but the device will transmit ultrasound energy to the surrounding vasculature. And the idea is to keep the endothelium cool, but be able to target the ultrasound energy at 1 to 6 millimeters into the vessel wall where the innervation is. And so this is a circumferential ablation targeting about 80% of the nerves at 1 to 6 millimeters in depth in the renal arterial wall. And in the proof of concept studies, so far the results have been promising. So there are different ways of doing this. One is with ultrasound, which I just mentioned. The other one is with radio frequency and the heat that's associated with it. And in these patients, the primary endpoint typically is ambulatory blood pressure monitoring, which is, I think, the best way to assess to see how adequately controlled blood pressure is. The medications, in some of these studies, the patients are not taking any medications. Some are taking medications. And the baseline blood pressure you can see here is typically around 150 systolic. In these studies, the nice thing is these are randomized, and in the patients who are randomized to the control group, they actually undergo a sham procedure, which just means that they have a catheter in the groin, but the actual procedure was not done. And that way, the patient does not know what type of treatment he or she receives. And then overall, there is a significant reduction in systolic blood pressure based on 24-hour or daytime ambulatory blood pressure monitoring. And so the technology that we are focusing on is the ultrasound, because with radio frequency, there may be a higher likelihood of endothelial damage from the radio frequency energy, whereas the ultrasound with a cooling system is more targeted to where the innervation is. So this trial is a randomized double-blind sham control study. So the patient does not know what he or she receives, which treatment. The physician who adjudicates the adequacy of blood pressure management is also blinded to the treatment. So it's a double-blinded control. So this is probably the best way to assess the safety and the efficacy of the ultrasound-mediated renal denervation treatment in patients, in this particular case, with stage 2 hypertension. So to qualify for the trial, the patients have blood pressures of higher than 140/90, but lower than 180/120, no more than 2 antihypertensive medications. And then their renal arteries have to meet anatomical criteria to be able to be enrolled in this trial. The primary outcome, the primary endpoints are looking at major adverse events from baseline at the time of the procedure to 30 days post-procedure, and then to look at the efficacy, which is the change in average daytime ambulatory systolic blood pressure, also from baseline to 2 months post-procedure. And the nice thing about this particular trial is that at the end of the trial, the patient is eligible to be crossed over. So for instance, if you are in the control group at 1 year, you are able to be changed back to the to cross over to the treatment group and receive renal denervation, assuming the technology is reasonable. And so we are conducting this trial. We've enrolled a number of patients. I am the site principal investigator. You can reach me by various means: email, secure chat, Epic messaging. Our research coordinator, who has done the bulk of the work, is Serena Risher, and the other investigators who are involved in the trial are Dr. Bizwas, Dr. Peterson, and Dr. Amro from nephrology. And with that, thank you for your attention. And I'm happy to answer questions. Great, I don't think there are any questions. So in that case, thank you very much.
Thank you. Thank you, Dr. Wang.
Thank you.